Good morning. Today's topic is the TE for congenital heart disease, atrioventricular septal defect. It is also called as AVCD. The AVCD, it is atrioventricular septal defect. It is also called as endocardial cushion or AV canal defect. It is characterized by a common AV junction or region of the heart where the atrial and ventricular myocardium becomes contiguous, as well as variable deficiencies in atrial and ventricular septation and an abnormal structure of the atrioventricular valve, leading to either the presence of common AV valve or the incomplete or abnormal development of two separate AV valves. These anomalies are the result of faulty AV septation. The embryological disturbance leading to this AVCD is due to the abnormal development of the endocardial cushions. There is increasing evidence suggests there is a potential role for the dorsal mesenchymal protrusion in the etiology of AVSD. The incidence of this AVCD is 4 to 5 per 10,000 live births, and it accounts for about 6% of the congenital heart disease, most common associated with Down syndrome. This is a diagram showing the common atrioventricular defect. Under AVCD or atrioventricular septal defect, it is classification by Dr. Robert Anderson and colleagues. It agrees atrioventricular septal defect into two forms, namely complete and partial. In a complete form of AVCD, a large common atrioventricular valve is present in association with large contiguous ASD and VSD, which allows for intracardiac shunting at both levels. The inferior portion of the atrial septum and the posterior portion of the ventricular septum are absent. These deficiencies correspond to presence of primum ASD in the lower portion of the atrial septum, which is directly above the atrioventricular valves, and an inlet type of VSD, which is directly below the atrioventricular valves, respectively. It's also called as scooped out appearance of the ventricular inlet. This is the most common form of the AVCD in children. In the partial form, the two separate AV orifices are present as a result of partial fusion between the superior and inferior bridging leaflets. An ostium primum ASD occurs when the valve leaflets adheres to the ventricular septum and completely prevent any ventricular communications. Shunting thus occurs only at the atrial level. A small VSD can be present if the leaflets attach to the ventricular septum but do not completely occlude the communication between the ventricles. Less common is the occurrence of the isolated ventricular component, also referred to as VSD of the AV canal type. It is greater when the atrioventricular leaflets adhere completely to the inferior portion of the intraatrial septum, thereby preventing any atrial shunting, yet allowing for ventricular shunting. AVCDs share common anatomical features, namely a defect in the AV septum, that is a region of the septum in the normal heart that separates the RA from the LV, is composed of membranous and muscular septum. The distinction between these forms is the degree of septation of the atrioventricular valve, in addition to the manner and extent to which atrioventricular attaches to the crest of the ventricular septum or atrial septum, which determines whether the atrial or ventricular shunting can occur. Less common variants are the common atrium. It is a defect in which virtually the no atrial septum is present. Isolated cleft or mitral valve are also one of the variant in which no atrial or ventricular communication is present. The recommendations from the American Society of Echocardiography for the AVCD, it is characterized by preoperative transthoracic echo before the transesophageal echo imaging. The pre-surgical transesophageal echo examination should then confirm or exclude the preoperative TTE findings, which allow for the assessment of immediate preoperative hemodynamics and provides a baseline evaluation of ventricular function. Key anatomical and associated hemodynamic features, in addition to other relevant information, can be immediately shared with the intraoperative providers before the surgical procedure is initiated. Preoperative TE evaluation of the AVCD. The use of TE in this setting has been shown to improve the surgical results by providing the surgeon with real-time information about cardiac anatomy and valvular function. Preoperative TE can also facilitate central venous access by documenting appropriate catheter positioning, assist in the selection of anesthetic agents, and serves to optimize hemodynamic management. In general, the important issues to be addressed in the preoperative TE study should include type and size of the atrial communications, type and extent of the ventricular communication, intracardiac shunting patterns, atrioventricular valve morphology and function, ventricular size and commitment of the atrioventricular junction to the underlying ventricular mass, associated cardiac anomalies, namely the additional VSD or PDA or presence of left superior vena cava to coronary sinus, and coincidental lesions of moderate complexity such as tetralogy of Fallot, and to evaluate the ventricular function. Atrioventricular septum and atrioventricular valve imaging. The AV septum is best imagined from the mid-esophageal four-chamber view at the angle of 0 to 10 degree. In this angle, the relation of the atrioventricular leaflets to each other and to septa can be visualized. In a complete AVCD, the atrioventricular valve appears to insert onto the IVS at the same level or in plane. In other words, there is lack of the offsetting present in the normal heart, where the mitral valve attaches to the septum more superiorly with respect to site of insertion of the tricuspid valve. This is a TE imaging showing the atrioventricular septal defect. The septal attachments of the caudate tendineae and papillary muscle of the left atrioventricular valve define the cleft, also called a zone of opposition or commissure, between the superior and inferior bridging leaflets. The anatomical boundary of the septal components of the defect can be examined in this view. Scanning posteriorly by using probe retroflexion in the mid-esophageal four-chamber view defines the posterior limits of the atrial and ventricular components of the defect. Locating the coronary sinus with probe tip retroflexion followed by slight antiflexion defines the position of the inferior components of the common AV valve as it bridges over the ventricular septum. The superior component of the common AV valve is correspondingly defined in this place by antiflexing the probe so that the bridging leaflet absorbs crossing the anterior aspect of the defect. This assessment can be achieved by withdrawing the imaging probe cephalad from this view to just the upper esophageal level, applying tip antiflexion, and then directing the scan plane slightly posteriorly by advancing the transducer to the mid-esophageal level until the superior bridging leaflet is identified. Advancing or withdrawing the TE probe shaft from the mid-esophageal four-chamber view along with the probe tip antiflexion or retroflexion allows optimization of the view and visualization of additional structures of interest. Antiflexion of the TE probe tip or withdrawal of the probe shaft from the mid-esophageal four-chamber view allows for the mid-esophageal five-chamber at the angle of 0 to 10 degree to be displayed. This view defines the anterior external septal defects, the relationship of the caudate tendineae to the underlying ventricular septum and the LVOT and the aortic root. The morphological features of the common atrioventricular valve, including caudal attachments, to be assessed in multiple views at mid-esophageal four-chamber view, mid-esophageal five-chamber view, mid-esophageal long axis view at the angle of 120 to 140 degree, transgastric basal short axis view at angle of 0 to 20 degree, and deep transgastric five-chamber view at angle of 0 to 20 degree, and deep transgastric RVOT at angle of 50 to 90 degree. This is a transthoracic parasternal short axis imaging demonstrating the cleft in the left atrioventricular valve pointing towards the inlet septum with the atrioventricular defect. This is a mid-esophageal long axis view in the TE image displaying the cleft in the left-sided component of the atrioventricular valve associated with abnormal valve motion. This is a diagram showing the balanced ABCD and unbalanced ABCD. In the panel A, there is a balanced ABCD where the atrioventricular valve lies equally above the ventricular mass, whereas in case of panel B, the atrioventricular valve is committed preferentially to the right ventricle, resulting in the right dominant ABCD and the hypoplastic LV, whereas in panel C, the left dominant ABCD where the atrioventricular valve is committed preferentially to the LV. And coming to the Doppler evaluation of defects, detecting intracardiac shunting patterns and evaluating valvular regurgitations are relevant for the surgical repair of the AVCD and for programmatic purposes. Color flow Doppler is useful for evaluating the magnitude and direction of shunting in all TE views. Shunting across an ostium primum defect occurs during diastole, and in most cases flow is laminar and of low velocity. The atrial component of the defect can be difficult to define when the common atrioventricular valve is open, especially if the opening is small, as there is complete communication between the atrium and ventricles. This may be better appreciated when the valve is closed. Color flow Doppler helps in determining flow when there is limited potential for intraventricular shunting under the superior bridging leaflets. Thank you.